Hello everyone. Today I will be talking about cholesterol clinical practice guidelines, a 2018 report from the American College of Cardiology and American Heart Association Task Force. Recommendations are designated with both a class of recommendation and a level of evidence. Class 1 is a strong recommendation, Class 2A is a moderate recommendation, Class 2B is weak recommendation, and Class 3 is no benefit. Level A is a high quality evidence, Level B is moderate quality evidence, Level C is expert opinion based on clinical experience. Serum cholesterol and its lipoprotein carriers such as LDL, VLDL, and HDL are known to be related to atherosclerotic cardiovascular disease. LDL cholesterol is the dominant form of atherogenic cholesterol. VLDL, which is the chief carrier of triglycerides, is also atherogenic. HDL cholesterol is not so much atherogenic. Although LDL cholesterol is a primary cause of atherosclerosis, there are other major risk factors such as cigarette smoking, hypertension, and diabetes that contribute to the atherosclerotic vascular disease. 20 recommendations for measurements of LDL cholesterol in adults who are 20 years of age or older and are not on lipid-lowering drugs. Measurement of either a fasting or a non-fasting lipid profile is effective in estimating atherosclerotic cardiovascular disease and documenting baseline LDL cholesterol. Class 1 recommendation. In adults who are 20 years of age or older and whom an initial non-fasting lipid profile reveals a triglyceride level of greater than 400 milligrams per deciliter, a repeat fasting lipid profile should be performed. Class 1 recommendation. In adults who are 20 years of age or older and without a personal history of atherosclerotic cardiovascular disease but family history of premature coronary artery disease, measurement of a fasting lipid profile is reasonable. Class 2A recommendation. Among lipid-lowering drugs, statins are the cornerstone of therapy in addition to healthy lifestyle interventions. Other LDL-lowering drugs include ezetimibe, bile acid sequestrin, and PCSK9 inhibitors. Statins are divided into three categories. High-intensity statin typically lowers LDL cholesterol by greater than 50%. Moderate-intensity statin, which lowers LDL cholesterol by 30 to 49%, and low-intensity statin, which lowers LDL cholesterol by less than 30%. Some common statins that fall under the high intensity group: atorvastatin 40 mg to 80 mg, rosuvastatin 20 mg to 40 mg. Statins that fall in the moderate intensity group: atorvastatin 10 mg to 20 mg, rosuvastatin 5 mg to 10 mg, simvastatin 20 to 40 mg, pravastatin 40 mg. Statins that fall in the low intensity group are simvastatin 10 mg, pravastatin 10 to 20 mg. Some non-statin add-on drugs to the statin therapy include ezetimibe, which lowers LDL cholesterol by 15 to 20%, bile acid sequestrant, which can lower LDL cholesterol by 15 to 30%, and PCSK9 inhibitor, which are powerful LDL lowering drugs which can reduce LDL by 40 to 50%. Secondary atherosclerotic cardiovascular disease prevention recommendations for statin therapy. In patients who are 75 years of age or younger with clinical atherosclerotic cardiovascular disease, high-intensity statin therapy should be initiated or continued with the goal of reducing LDL cholesterol by greater than 50%. Class 1 recommendation. In patients in whom high-intensity statin is contraindicated or who experience statin-associated side effects, moderate intensity statin should be initiated or continued with the goal of reducing LDL cholesterol between 30 to 49%. In patients with clinical atherosclerotic cardiovascular disease who are very high risk and who are on maximally tolerated LDL lowering therapy, it is reasonable to add ezetimibe or PCSK9 inhibitor if their LDL cholesterol is still greater than 70 milligrams per deciliter. Recommendations for statin therapy used in patients with atherosclerotic cardiovascular disease. In patients older than 75 years of age with clinical atherosclerotic cardiovascular disease, it's reasonable to initiate moderate or high intensity statin therapy. If patients older than 75 years are tolerating high intensity statin therapy, it's reasonable to continue on that. Class 2A recommendation. In patients with clinical atherosclerotic cardiovascular disease who are on maximally tolerated statin therapy and whose LDL level is greater than 70 milligrams per deciliter, it is reasonable to add ezetimibe. Class 2B recommendation. Major atherosclerotic cardiovascular disease events include history of myocardial infarction, recent acute coronary syndrome within the past 12 months, history of ischemic stroke, symptomatic peripheral arterial disease. High-risk conditions for future atherosclerotic cardiovascular disease events include age greater than 65 years, familial hypercholesterolemia, history of prior coronary artery bypass surgery, diabetes mellitus, hypertension, history of congestive heart failure, current smoking. Recommendations for primary severe hypercholesterolemia with LDL cholesterol greater than 190 milligrams per deciliter. In patients 20 to 75 years of age with LDL level of 190 milligrams per deciliter or higher, maximally tolerated statin therapy is recommended. Class 1 recommendation. In patients 20 to 75 years of age with LDL level of 190 milligrams per deciliter or higher who achieve less than 50% reduction in their LDL cholesterol while on maximally tolerated statin therapy, add ezetimibe therapy. Class 2A recommendation. In patients 40 to 75 years of age with baseline LDL cholesterol of 220 milligrams per deciliter or higher and who achieve on treatment LDL level of 130 milligrams per deciliter or higher while on maximally tolerated statin and ezetimibe therapy, add PCSK9 inhibitor. Class 2B recommendation. Recommendations for patients with diabetes mellitus. In adults 40 to 75 years of age with diabetes mellitus, regardless of estimated 10-year atherosclerotic cardiovascular disease risk, moderate intensity statin therapy is indicated. Class 1 recommendation. In adults 40 to 75 years of age with diabetes mellitus and LDL level of 70 to 189 milligrams per deciliter, it is reasonable to assess a 10-year risk of a first atherosclerotic cardiovascular disease by using the pooled cohort equation. In Class 2 recommendation. In adults with diabetes mellitus and a 10-year atherosclerotic cardiovascular disease risk of 20% or higher, it may be reasonable to add ezetimibe to maximally tolerated statin therapy to reduce LDL cholesterol by 50% or more. Class 2B recommendation. In adults with diabetes mellitus who have multiple atherosclerotic cardiovascular risk factors, it is reasonable to prescribe high-intensity statin therapy with the aim to reduce LDL cholesterol by greater than 50%. Class 2A recommendation. Diabetes-specific risk enhancers are long duration, greater than 10 years for type 2 diabetes mellitus or greater than 20 years for type 1 diabetes mellitus. Albuminuria with greater than 30 micrograms of albumin per milligram of creatinine, GFR of less than 60 ml per minute, diabetic retinopathy, peripheral neuropathy. It is well recognized that the frequency of a first atherosclerotic cardiovascular disease event in adults with diabetes mellitus is significantly increased compared to with those without diabetes. Atherosclerotic cardiovascular disease risk increases incrementally with age in people with diabetes mellitus. Primary prevention of atherosclerotic cardiovascular disease using drug therapy is needed in 3 categories. Number 1, if the LDL cholesterol is greater than 190 milligrams per deciliter, initiate high-intensity statin. Class 1 recommendation. Number 2, if in age group of 40 to 75 years and with diabetes mellitus, initiate moderate intensity statin. Class 1 recommendation. Age 40 to 75 years of age without diabetes and LDL cholesterol between 70 to 190 milligrams per deciliter. Assess 10-year atherosclerotic cardiovascular risk assessment with pooled cohort equation. Less than 5% is low risk, between 5 to 7.5% is borderline risk, and if a patient has risk enhancers, then initiate moderate intensity statin. Atherosclerotic cardiovascular disease risk enhancers include family history of premature coronary vascular disease, persistently elevated LDL greater than 160 milligrams per deciliter, chronic kidney disease, metabolic syndrome, inflammatory disease such as rheumatoid arthritis, South Asian ethnicity. If the 10-year risk is between 7.5 to 20%, it's intermediate risk. Initiate moderate intensity statin. If it is greater than 20%, initiate high intensity statin. Recommendations for primary prevention in older adults. In adults 75 years of age or older with LDL cholesterol between 70 to 190 milligrams per deciliter, initiating a moderate intensity statin may be reasonable. Class 2B recommendation. In adults 75 years of age or older, it may be reasonable to stop the statin therapy with functional decline or reduced life expectancy. Class 2B recommendation. Recommendations for hypertriglyceridemia. Two categories of hypertriglyceridemia consist of moderate, where the fasting or non-fasting triglyceride level is between 175 to 499 milligrams per deciliter, and severe hypertriglyceridemia, where the level is greater than 500 milligrams per deciliter. In adults 20 years of age or older with moderate hypertriglyceridemia, where the triglyceride level is between 175 to 499 milligrams per deciliter, clinicians should address and treat lifestyle factors such as obesity and metabolic syndrome, secondary factors such as diabetes mellitus, chronic kidney disease, and medications that increase triglyceride level. Class 1 recommendation. In adults 40 to 75 years of age with severe hypertriglyceridemia, where the level is greater than 500 milligrams per deciliter, and atherosclerotic cardiovascular disease risk of 7.5% or higher, it is reasonable to address reversible causes and initiate statin therapy. Class 2A recommendation. Recommendations for adults with chronic kidney disease. In adults 40 to 75 years of age with LDL cholesterol between 70 to 190 milligrams per deciliter who are at 10-year atherosclerotic cardiovascular risk of 7.5% or higher, initiation of a moderate intensity statin can be useful. Class 2A recommendation. In adults with advanced kidney disease that require dialysis treatment who are currently on LDL lowering therapy with a statin, it may be reasonable to continue the statin. Class 2B recommendation. In adults with advanced kidney disease who require dialysis treatment, initiation of a statin is not recommended. Class 3 recommendation.